My name is Wojsech Gоншор. I'm from Gliwice. I'm physiotherapist from Rehab clinic. For start, thank you for having me here. It's my first time in Bulgaria, and I really like it. So the topic of my presentation will be traction therapy on the Platinium table, effectiveness and implications for rehabilitation practice. So let's start with the back pain. So lower back pain is one of the most common health problems in the general population. It's estimated that 60–80% of people experience it in their lifetime. Lower back pain is also most common cause of work incapacity among people under 45 years of age. About 4 to 15% of the population suffers from the chronic form of this condition. So traction. Traction is a therapeutic technique that applies in a stretching force along the axis of the spine to reduce pressure on the nerve structure, relieve invertebral disc, relax soft tissue, improve range of motion. It can be performed manually by a therapist or mechanically using special devices like the Platinium table. So, despite the potential benefits of manual traction in alleviating the pain, its utilization is not widespread. For instance, in North Ireland, only 15% of patients receive traction, compared to 31% in the UK and 58 to 77% in the US. In Poland, I think we've got the same ratio as in the United States, because we've got a lot of manual therapists working with traction by their hands, I mean manually, and we also got a lot of table. Like Technomex company sold almost 1,000 Platinium table in Poland. So biomechanical of traction. Application of traction force causes separation of adjacent vertebral bodies, which consequently leads to decrease the pressure within the annual fibrous. Studies have demonstrated the formation of the negative pressure rating from 50 to 100 millimeters when traction is applied with a force of 35–50 kilograms. So in the theory, the process leads to the retraction of herniated nucleus pulpus material toward to the center, resulting in a reduction of its volume. I think it's not true. I think it's not possible to reduce nucleus pulpus without any surgery. If a discopathy happened, all the physiotherapy can do to reduce the pain, reduce the inflammatory process. And I think this mistake is from that when the inflammatory process is set, the nucleus pulpus swollen, and after relieving the pain, using the traction to reduce inflammatory process, it's reduced its volume, but it's only because of reducing inflammatory process. Like I said, it's not possible to to do something on nucleus pulpus without a surgery. So increase on invertebral space. Stretching results in vertebral separation, reducing the load on a joint and nerve structure. Increase in vertebral space may relieve compressed nerve roots. Studies observe a separation on 1 to 3 millimeters in the L2, L5 segments during gravitational traction. So traction gently stretches anterior and posterior longitudinal ligaments and interspinous ligaments. Nerve root decompression. So in pathological conditions such as herniated disc or spinal stenosis, nerve roots are often compressed, increasing the space in invertebral foramina along with reduced disc protrusion, help alleviate nerve root compression. So traction causes slight separation of face of joint surface, reducing their compression, which can relieve pain due to overloading or degenerative changes. Paraspinal muscular relaxation. So spinal stretching leads to the reflex relaxation of paraspinal muscle. Muscle tension reduced to testing levels or below occurs after 4 or 7 minutes of traction. So we've got type of traction. The first of one is continuous traction. this kind of traction is not relevant because the traction have to last at least 5 hours. So it's not possible to get the traction of 5 kilograms to the patients for the 5 hours. So the second type of traction is sustained prolonged traction. The static traction is applied up to 30 minutes, optimal time 20 to 50 minutes. The load can reach up to 60% of the patient's body weight, but should be not exceed 50 kilograms for the lumbar spine and 50 kilograms for the cervical spine. To be honest, I work on the traction table for 7 years. It was only one time when I have to do 50 kilos of traction because the patient weighed 170 kilos. It was only time that I have to go to the 50. And in my experience, the most optimal time is 50 minutes. We do the traction for I never did more than 15 minutes of traction in my whole life. Intermittent mechanical traction performed using device that apply and release traction in cycles. Harmonical variable without maintaining peak traction force, and intermittent variable with maintenance of peak traction force. And in my opinion, in my experience, the intermittent traction is the most useful traction that we can get because it helps with the nerve problems and the muscle problems. So static we use only for the disc inflammation, and rest of things we can do with the intermittent variant of the traction. So indications: herniation or protrusion of invertebrate disc, radicular syndromes of various origin and stages, degenerative changes of the spine, spinal pain syndrome with a muscular component, joint pain, spinal canal stenosis. But if we're dealing with a real stenosis, like the true stenosis, when the root, when the nerve have no movement in the canali, then traction won't do nothing. In my experience, when we're treating a normal stenosis that is confirmed by MRI and the root have no space to move in the nerve canali, that only surgery will help. But in Poland, we've got a lot of patients that are diagnosed with stenosis without any MRI or without any examination. It's just like the patient that have radiating pain to the leg is often diagnosed with stenosis, but it's not true. It's not a real stenosis. In my opinion, it's the wrong diagnosis, and if it's wrong, we can help it, but if it's a true stenosis, only a surgery can help the patient. So contraindications, conditions where movement is not contraindicated, implants, hypermobility, excessive joint laxity, cardiovascular and respiratory issues, claustrophobia, spinal tumors, spinal cord compression and myelopathy, local infections, inflammatory conditions, osteoporosis. So in X-Rehab in Gliwice, we decided not to do traction to the patients that have injured spine or have spinal surgery. Even it was like, it was a surgery called microdiscectomia, which they cut the nucleus pulpus with laser, and theoretically there is no contraindications to do traction after this surgery. We don't do it. We never have been brave enough to do the traction to the patients after the surgery or after the fraction. Even this is a young patient after the fracture, and like I said, any surgery, we do not do the traction. So like another contraindications, fresh fractures, abdominal hernia, pregnancy, uncontrolled hypertension, cold or flu, tuberculous arthritis, and system related to dura mater. About the pregnancy, my colleague did few times the C-spine traction on the pregnant woman. I do not work with the pregnant woman, so I do not do it, but my colleague that worked said it's okay. It's never ever happened. But like I said, the traction of the C-spine, not LS spine. It was the traction of the C-spine with the arm pain. So the contradictions due to the patient's general condition is mostly the same contradictions to the regular physiotherapy. So unstable clinical condition of the cardiovascular and respiratory system, symptoms of the cardiovascular and respiratory failure, inability to move independently, post-fracture, post-spinal surgery conditions, conditions in which increased intra-abdominal or intrathoracic pressure is contraindicated, lack of cooperation with the therapist, urgent indications for surgery or suspected need of urgent surgical interview until ruled out. So criteria of traction, force, time, and positioning. So the force, traction always have to be applied without pain or discomfort, only with a stretching sensation. Even when a few years back, I do my traction with my hands, so I do it manually without using any table. I never did it with the pain. So in Poland, we will learn not to, that any kind of traction have to be applied without any pain. So we start with much lower values, 30 to 50% of the planet force, and gradually increase the substantiation sensation. For the muscle relaxation, lower forces are better. For reducing this protrusion, higher forces are used. So on the cervical spine, force up to approximately 10 kilograms. Higher force does not produce greater effectiveness and may cause discomfort, necessitating in the termination of the procedure. In my experience, I never did more than 10 kilos. If I do the traction with the 10 kilo of the force and I don't have and patient don't go better, I quit doing the traction. I never did more than 10 kilos on the C-spine in my whole life. Lumbar spine, the most commonly recommended force are around 30 to 50 of the body weight, which is maximum absolutely 50 kilograms. 30 kilograms will be the most of the force you will apply is 25-30 kilograms when you start working with patients of the traction. There are no reports indicating a direct correlation between traction force and therapy effectiveness, and lower traction force are likely sufficient to achieve therapeutic effects. Like I said, 30 kilos is enough. I start with 10 kilos, then next session 15 kilos, next session 20, and 20 to 30, sometimes patients said it's enough for me, let's keep it that way. But in my opinion, in my experience, on the lumbar spine, 20 to 30 kilos is the best force. Sometimes if the patient is very, very big, then we have to go more. So forces below 25% of the body weights are probably adequate. A mechanism after was observed in cadaveric spine studies at as little as 9 kilo. In my opinion and my experience, is not enough. It had to be more. Okay, so force above 150 kilo may cause damage to the healthy tissue. So recommended treatment duration is 10 to 30 minutes. 15 minutes is the best. It's enough. It just works the best at 15 minutes. No matter is the muscle restriction, the nerve problem, or the disc, 15 minutes is unique best time for the traction, in my opinion and my experience. So positioning, always in relaxed position, arms along the torso, never behind the head. For cervical spine, neutral position for mid-cervical effects, flexion for lower cervical spine, and for lumbar spine, neutral position or with straight legs for a lower. So for cervical spine is true, but for the lumbar spine, in my experience, it's no difference. Even if the legs, the flexed knees always. So for the C-spine is important because when you have like C7 problems radiating to the fifth finger, you have to make the head flex to act on this spot. But for the lumbar spine, it's no different. So the strap fastening best secured on the bare skin is not. It's also, you can do it easy with clothes. Okay, so various patients' reaction to treatment. So after traction, spinal mobility decrease, similar to the after night's rest. That's happened very often. I can tell that 6 of 10 patients after the first procedure will have the spinal mobility decrease. If the force had to be reduced and symptoms worsened after traction, treatment should be not continue. If symptoms do not worsen, treatment may continue. If the first traction is too strong and the patient gets up too quickly, there may be a significant increase in symptoms. And this will happen, but not that often as the mobility decrease. So during the first treatment, it's absolutely essential to remain still after the end of the traction. So after the end of the traction, patient have to lay for a little bit. On the first treatment, even the same time that the traction. The patient should be instructed to get up through the side. It's recommended to inform the patient that symptoms may worsen after the treatment. Symptoms mostly common appear after getting up from the table, and it can last up for 20 minutes. In such case, the patient should avoid static position and be advised to walk off the pain. I sometimes, after the traction, the symptoms were terrible. The patient said that the pain is worse than he started, but it never took more than 20 minutes to walk it off. But it will be happening, but it never happened to me that it lasts more than 20 minutes. Traction is often combined with passive stretching exercise in case of acute or moderate disc protrusion. So traction is rarely performed as standalone treatment. I never did traction as standalone treatment. It always a part of treatment. In my daily basic work, I start with manual therapy. I often try to manipulate the joints. Then I do traction, and after this, the patient do exercise. After the traction, we can do even the weight training. It's not like there is any contraindications to training after the procedure, and physical therapy. So if there is no improvement after 2-4 sessions, consider changing the treatment method. If the patients do not feel better after 2 to 4 sessions, I do not do traction. I just leave it, changing my treatment method. So thank you for your attention.